So Forrest is an interesting case and probably all too typical. He's a 11-year-old, nice young man who was just a normal kid and then developed some pain in his right lower quadrant. And the history is a little bit unclear on this. The thought is that this was related to some kind of GI illness. These are the terminal branches or the very ends of the intercostal nerves that come from the spine, wrap around underneath the ribs, and then come into the abdominal area to innervate the anterior abdominal wall. The condition is called anterior cutaneous nerve entrapment syndrome, where that terminal nerve branch, which comes out through the rectus muscle, the six-pack muscles, one on each side, that nerve will come out of the muscle, pierces through this tough fascia that's on the front of that muscle, and then comes up into the fatty tissue to innervate a patch of skin. If there's an injury to the muscle or blunt trauma to the abdomen, that nerve can get scarred in where it's coming out of the muscle and through that anterior rectus sheath. And then it's just like a toothache, you know, it can just cause severe pain. These children end up going through very dramatic workups, and Forrest is no exception. He had multiple upper endoscopies, colonoscopies, a capsule endoscopy, MRI and CT image of his whole body, including even a brain MRI. He was put on multiple different medications, from narcotics to antidepressants to neurogenic medications to see if anything would work, and none of that did. He even underwent a sort of an exploratory laparoscopy, and they ended up taking out his appendix, even though it didn't look like there's anything wrong, but you know, you're there and the thought is, why not, you know? I was 90% sure that he had anterior cutaneous nerve entrapment syndrome just because of the summary that his mother sent, which was an excellent detailed summary, the location of his pain and how the pain was stimulated by any kind of physical activity, any tension put on the abdominal wall, or any compression, and just pushing on that one place. It was such a focal pain just in the same area, never moved. That's sort of all classic for an anterior cutaneous nerve entrapment syndrome. Physical examination is really key in these patients, and so you can really just, it's actually hands-on the patient, which is sort of a lost art form these days, but you can palpate around and pretty much identify right where this nerve is entrapped. Now these nerves can be really tiny, you know, less than 1 millimeter to 1 millimeter in size. And so when you're having a true anterior cutaneous nerve entrapment, you generally just make an incision right over the point of maximal tenderness. And then it's very careful, meticulous dissection down through the subcutaneous tissue using bipolar cautery, so there's really a bloodless feel. That's key, because if things get bloodstained, you can easily miss the nerve, or the differentiation between a nerve and a small vessel can be lost. You just go down and you find the nerve, and very often there is a little vessel traveling with it. You just find it and follow it back to its point of exit from the rectus sheath. You open up the rectus sheath, and then you take this nerve and dissect it down into the rectus muscle. And you got to make sure that you're past any point of scarring of the nerve to either surrounding muscle or the rectus fascia. And once that nerve is sort of gliding, then you disconnect it, you excise the distal portion, and you take the proximal end and just bury it down in the central substance of the rectus abdominis muscle. And it's like getting a cavity filled. You go in with a horrible aching pain, you get the problem resolved, and you come out and your pain's gone. And that's pretty much what it is for these surgeries. There's obviously a little discomfort with the surgical incision itself, but most of the time these patients know right away within a day or two, if not immediately, that their original pain is gone. It's super rewarding to be able to help a young person like this, because I mean, it's tragedy enough if somebody in their 60s is debilitated with chronic pain. These patients, if they don't find a solution, their life is effectively over. Everybody just kind of throws up their hands and gives up a lot of times. And that's really what's led to the development of the pain management specialty, because there's millions of people that deal with chronic pain that nobody really understands where it's coming from. And so it's like, well, let's just try and manage it. A straightforward, simple ACNES case is pretty easy to deal with. It's crazy how simple the solution is versus the damage that's done by not addressing it.